So good morning again. My name is Tim Brewweiler. I'm a PGY2 resident at WVU in Occupational Medicine, and I'm here to talk about mostly hypersensitivity pneumonitis. Next slide. I'm going to break a cardinal rule here and read the slide, but I want to be able to talk about it some more afterwards. And if and the pictures in the background were something my wife was like, look, you got to put these in here. Everyone's going to fall asleep. There's too many words in these slides. So there's some pictures in follow on, and thank Amy for that. Hypersensitivity pneumonitis. It's an interstitial lung disease characterized by a complex immune reaction of the lung parenchyma in response to repeated inhalation of a sensitized allergen. The inflammation involves both the alveoli and the bronchioles. Clinical presentation severity depend on inhaled antigen and quantity. It was first described about 1700 by the Italian physician Bernardino Ramazzini. He is known as the father of occupational medicine. He found it in workers belonging to several professions. When I was reading a little bit of one of his books, it's definitely commented on in flax, hemp, and silk workers. So the challenge with HP is that there's over 300 antigens, and they try to break them down into low molecular weight antigens and large molecular weight antigens. And the exposures are different. A lot of what we'll talk about has to do with farmers and bird breeders or bird fanciers, because that's where a lot of the studies have been from. And again, with farmers, it's going to be more seasonal. There's a study out of Scandinavia that showed it more in the end of the winter season when they have the hay that's, had more time to ferment, if that's the correct word. Someone will correct me later. But it had more fungal growth at that time. Let's see here. Yeah, that's about it. Next slide, please. So it said interstitial lung disease. So in bottom left of the picture is the alveoli, and the interstitial space, this cream colored space between the capillary bed, the capillary network and the alveoli, is supposed to be about 1 cell in thickness. And the challenge here is a chronic inflammatory response that now thickens that layer. And I was thinking of it recently about how you go into some of those neighborhoods with HOAs where you can't share a fence, or maybe the folks living next to each other don't want to share a fence, so they each put a fence on each side of their yard, right? So it's, say, 6 inches in of the property line on each side. Well, that's a thicker barrier, so to speak, right? So if you have 2 friendly dogs, they're not going to be able to hang out, are they? Okay. Next slide, please. The overall prevalence, epidemiology, prevalence and incidence are thought to be low, but again, there's challenges in case definitions, intensity of exposures, the seasonality we spoke about, geographic conditions. Much of the information we have is, again, from farmers and bird fanciers. A piece of the challenge that's helpful from the primary care perspective is that mild or subclinical HP can escape detection. You have to really walk in the door thinking about it. So it can escape detection. It'll be misdiagnosed as a viral illness or asthma. It can be kind of challenging because it has non-specific clinical findings. There was one study done from a large medical database in the U.S. that found prevalence of HP to be about 1.6 to 2.7 per 100,000 persons, but that it increased with age to be about 11.2 per 100,000 for those older than 65. Next slide, please. Interesting piece to HP is they found that if you were a smoker before exposure to antigens, you were less likely to develop HP. but that if you do indeed develop HP and you are a smoker, it would predispose you to more chronic and severe disease. Next slide, please. Farmer's lung is estimated to be about half to 7% of the farming population. Bird fanciers, again, challenging numbers, but prevalence of HP to be about 20 to 20,000 per 100,000 persons at risk. The reason only a small portion of exposed individuals develop clinically significant HP is not known, although genetic factors are postulated to play a major role in determining an individual's risk. Likely, the immune abnormalities underlying HP reflect the interplay of multiple genes involved in the immune response. It's kind of challenging because there's no specific dose-response curve. Next slide, please. Farming, vegetable, and dairy cattle. Dairy cattle workers. Again, farmer's lung is one of the more common. There are many different antigens, but the main source is the growth of thermophilic actinomyces in hay or dust in areas of high humidity and temperatures of about 104 to 140 Fahrenheit. Interestingly, it appears that the round bales, as opposed to the older rectangular bales, have higher compaction and lead to higher humidity, leading to increased microbial growth. A thing to keep in mind is that HP in farmers must be distinguished from febrile toxic reactions to inhaled mold and dust. Check my notes. Organic dust toxic syndrome is a non-immune reaction that occurs 30 to 50 times more commonly in HP than HP in farmers. HP is associated more with exposure on most days, high exposure on most days with prolonged periods, while organic dust toxic syndrome is associated with more of an intense exposure occurring on a single day. And I mentioned before, it was a febrile illness, ODTS, organic dust toxic syndrome, where they'll have a fever, sometimes weakness, headache, chills, body aches, cough, and shortness of breath. Next slide, please. So HP can be caused by microorganisms that colonize forced air systems, heated water reservoirs, humidifiers, vaporizers, swimming pools, whirlpools, hot tubs, water flume slides. Usually it's of the Penicillium or Aspergillus species. I was reading more about this and I felt like it's more of like, if you build it, they will come. So if you have stagnant water in places, it's more like, especially places that can be aerosolized. There was one study about indoor water park where about 60% of the lifeguards were affected, and it was from these sprayers because the sprayer heads were contaminated. Another piece when I was reading is that Mycobacterium avium complex can cause hot tub lung even in immune competent hosts. Next slide, please. It can be induced by exposure to excreta and proteinaceous material on dried, finely dispersed dust with pigeons. I'm just going to call them budgies and parakeets, along with canaries, basically birds. An interesting piece about the poultry workers and the feather pickers, I think, is also remembering that it's stirred up. It's not just sitting on a surface. I saw someplace, where was that? I guess in hunting season, if you go goose hunting, you can go someplace and it's got this machine that'll it's like rubber fingers, and you throw the duck or the goose in this rubber finger machine, and it'll scrape off the feathers. And I would be concerned about workers in that kind of area, again, for the aerosolization of the large molecular weight antigens. Also to keep in mind is where's, is air intakes. So is the air intake for air conditioning systems near a spread of droppings? Or basic things like feathered pillows, wreaths, and down comforters. Next slide, please. In the background picture is pressboard. Pressboard will be infiltrated with glues, and then they are pressed together under high heat and pressure, and that can have a lot of mist and haze and aerosolization of antigens. So other occupations that we haven't talked about yet are grain and flour processing, lumber milling, wood stripping, plastics, paint, electronics industry, and other chemicals. And again, also at risk for occupational asthma or rhinitis. The textile workers, it appears the nylon flock is, or flock in general, which could be more of like a dust as they go through this rotary cut machine that takes like a string and then chops it up into pieces, into fine pieces. Next slide, please. This was a smaller list that I found that was readable, breaking down low molecular weight antigens and high molecular weight antigens. Isocyanates are more for paints and glues, and hydrides for plastics and epoxies. Something else, or wood dust. Western red cedar is a common one. High molecular weight, we talked about animal proteins and flours, along with enzymes that might affect workers like bakers. Next slide, please. The immune pathogenesis of HP is complex and varies with the affected individual antigen frequency and intensity, as well as duration of disease. It remains unclear why only a few of the individuals exposed develop the disease. There's a two-hit hypothesis that's been suggested, where antigen exposure acts as the inducing factor and genetic or environmental factors act as a promoting risk factor. I use the term acute in here, and it's the pulmonologist won't like it. So we'll say in an initial bout of HP, individuals exposed to a culprit antigen develop IgG antibodies to that antigen, and with subsequent exposures develop episodic lung inflammation with immune complex formation and an influx of neutrophils. So, because a lot of the other reading I've seen is they want to talk about more of the cell-mediated response, the non-antibody response, but we have to get there somehow. So, and I say I don't want to use the word acute because we'll talk about it in a few minutes, or might even be the next slide. How we've gone away from talking about acute, subacute, and chronic disease in HP. Next slide, please. So I don't know about you, but I've forgotten a lot of this, and I had to relearn it. Trying to break down the types of hypersensitivity reactions. So on the left, and this is another way to look at it, is fast and slow. So you've got columns for hypersensitivity reactions, type 1 through 4. Type 1 is more IgE and within seconds to minutes, immediate or like an anaphylactic reaction. And type 3 is antigen antibody complexes. It's within hours. And type 4 is more of days, about a lot of places I've read about are 1 to 3 days. It's a delayed response, no antibodies involved, it's cell mediated. Next slide, please. So the second half of this picture, the bottom half of this picture, is explaining more of the type 1 reaction that you'd see more in asthma, where the antigen comes in that you've seen before. IgE is attaching to it, which then connects to a mast cell and causes degranulation of the mast cell. Histamine is released, which then recruits more eosinophils. Next slide, please. Type 4 sensitivity, again, is delayed. It's several days, 1 to 3 days later. Cell-mediated, no antibodies are involved, but the body is aware of this antigen, has been sensitized to it. So you're exposed to this antigen again. The antigen-presenting cell brings this information to a CD4, which then releases IL-2, which increases interferon gamma and tells basically the macrophages to go and create granulomas of these antigens. And that's where further down the road in HP, how the granulomas are formed. Next slide, please. So in 2020, the American, Japanese, and Latin American thoracic societies got together and made a guideline for hypersensitivity pneumonitis. They wanted to go away from, again, like I was saying before, the acute, subacute, and chronic, because they didn't feel like it was objective enough. And not everybody goes from, not every patient will go from, well, in an acute phase, and now they're in subacute, and now they're chronic. It's not a serial, it's not always a serial disease. Some people can come in with granulomas and minimal to no symptoms. Whereas a granuloma you would expect to be more of a chronic issue. So they shifted to, in this 2020 guideline, they shifted to more of classifying HP into non-fibrotic or purely inflammatory, and fibrotic or mixed inflammatory plus fibrotic. Okay, next slide, please. Common symptoms in HP are dyspnea and cough. A challenge when working with these patients is that the chest tightness, constitutional symptoms, fever, chills, weight loss, malaise are less common. And symptoms, again, can be varied. They can present acutely, days to weeks, or insidiously, months to years later. Or they could just have recurrent episodes. Physical exam, some may have findings, may have tachypnea, focal or diffuse crackles, mild inspiratory squeaks, chirping or squawks. Wheezing is rare. And for more evolved disease, digital clubbing can be seen. Next slide, please. Another challenge with HP is that the chest radiograph can be normal, Sometimes you can see micronodular or reticular opacities, but that would be a challenge if I was working on a patient. And it's interesting that I'll go through it more later, but it's interesting, or frustrating, I should say, is if I'm thinking down the road of HP, it's like, oh, the chest X-ray is normal. Oh, okay. Am I going down the right road? But that was another thing that the HP guideline talks about is, and we'll talk about it in a second, is going and ordering an HRCT, high resolution CT. Opacities. In a series of bird fancier patients, the upper lung zone was frequently affected, while in a series of patients with something called summer type hypersensitivity was in the lower lung zone. Summer type I wouldn't worry about. This is more of a disease found in the summers in increased humid environments in Japan. Next slide, please. Initial evaluation. So I think first and foremost you have to think about it and think it's out there. Think it's a possibility. Put it on the differential. It should be suspected in patients with known exposure to a causative agent of HP, and in patients with clinical and imaging evidence of interstitial lung disease without features of an alternate diagnosis, such as sarcoid, rheumatic disease, drug exposure, cystic lung disease. A focus of the evaluation is to identify exposures, determine severity of respiratory impairment, and identify characteristic imaging. When the diagnosis remains uncertain, multidisciplinary evaluation can help guide the decision to pursue further evaluations such as bronchoalveolar lavage or tissue sampling. It's the challenge with the guidelines, the 2020 guidelines on HP, is that they lean on this heavily, but that's the pulmonologists leaning on radiology and pathology. And if we're talking about pathology, then we're out of the primary care realm where this is what this lecture is going to. So that's kind of a challenge, right? It's the more I read about HP, the more I got confused about it, because it's there, but you can't nail it down. I think more than anything, you have to just keep it in your mind, and we'll talk about it some more. It is a frustrating disease. So a focus of the evaluation is to identify potential exposures, determine severity, identify characteristic imaging. When diagnosis remains uncertain, a multidisciplinary evaluation can help guide the decision. So I know I'm reading it twice, but it's more of like, okay, just know when to ask for help. And I read this and I'm so frustrated as I'm trying to give this information out to primary caregivers, primary providers, because you have 5 minutes or 7 minutes to see the patient, and I don't have much of an answer for you. Exposure history. So the first step in evaluation of a patient with suspected HP is a detailed history of potential occupational, hobbies, and domestic exposures. It can help to use a questionnaire. There's none that have been validated, but we've got some basic questions on the next page, or a few slides on. Antigen and source of exposure are not identified. This is another one that's frustrating. Antigen and source of exposure are not identified in up to 60% of patients with HP, despite a thorough history. So I know. I'm glad I'm on the computer and you can't stab me for this one. As I tell you that, hey, you should get a good history, but 60% of the time we don't find it. Yeah. Next slide, please. Okay. So a reminder. So this, you could have them fill out something like this in the waiting room, narrow down their symptoms at the top. What are their symptoms? Did they start new employment? Did they start a new process? Was there a new exposure? Okay, is it a vapor, a gas, a fume, or dust at work? Are they feeling better on weekends? Are they feeling better, at, on vacations? I have one patient that, you know, is kind of a challenge because he doesn't feel better, but on vacation, but when he comes back to work, he has a coughing fit for a couple days. Or let me see here. And another point is what are other workers doing? Do other people at work have similar symptoms, or have people left work because of symptoms? And then some basic occupations that might have an increased risk of HP. Next slide, please. Lab testing is, the short answer is it's not very helpful. So lab testing for specific sensitivity to culprit antigens is limited by the high rate of positive tests among individuals who are exposed and well, have been exposed to this antigen and have no symptoms, and a high rate of false negative serologic tests. So, I guess we can test them for isocyanates or for formaldehyde or an anhydride, but it wouldn't help us treat the patient nor know that, oh, well, this test positive for anhydride, you have HP. PFTs will help. Pulmonary function tests will help. And again, it's not definitive if it's just a restrictive pattern. But PFTs are useful to assess the pattern and severity of respiratory impairment. And not able to differentiate non-fibrotic from fibrotic. And patients with non-fibrotic disease are more likely to demonstrate improvement after cessation of exposure. Patients with HP usually have a restrictive ventilatory defect and may have reduced pulse ox saturation. However, an obstructive or mixed pattern can be seen. Next slide, please. So as mentioned in the 2020 guidelines, pulmonologists recommend a high-resolution computed tomography when evaluating these patients, as it's more sensitive for detecting abnormalities and offers a greater definition of patterns and information on the presence or absence of features suggesting fibrosis. It'll also pick out air trapping. Next slide, please. Antigen avoidance is a main piece of this treatment. So maybe it's as simple as removal of feather bedding or birds in the home, avoiding hot tubs, and workplace mitigation. Can they be in an office that's further away from the exposure? Can they be in the control room versus out on the floor? Trial of antigen avoidance that leads to resolution of symptoms and radiographic opacities lends supportive evidence to a diagnosis of HP, but is not standardized. A challenge is that if you have fibrotic disease already, you may have only partial or no improvement following removal from the exposure. All right, next slide, please. Again, treatment, antigen avoidance. We talked about the birds and feathers, but we can talk about water plume slides, if that's in your work environment, humidifiers and vaporizers. A big challenge and something that I wouldn't want to have to tell my patient is if they had to move jobs, because sometimes it's hard to find a job that makes that same amount of money, right? Steroids. Um, Based on experience from studies of farmers and bird fanciers, it suggests a short course of oral steroids in patients with HP and moderate respiratory impairment help, but long-term outcome appears unchanged by glucocorticoid treatment. Other things that would be down the line to talk to a specialist about are azathioprine, mycophenolate, MMF, mycophenolate mofetil, as well as monoclonal antibodies for those with fibrotic disease. That's down the line with specialists. Next slide, please. This is just talking about, some recommendations on who would be a good patient for oral steroids, and they talked about dosages of about half mg per kg, 0.5 milligram per kilogram for up to 30 milligrams a day, treat them for about 2 weeks, and have a taper. Let's go a couple slides. So next slide, please. There's some references, but I had some extra slides I wanted to go through. So next slide. Okay, so this is from a CT showing upper lung zone reticular fibrosis and some honeycomb. Next slide, please. This one's showing more of the air trapping on exhalation. And next slide, please. For me, I always forget. I just wanted to put this in the back because I was trying to have things in here that were helpful for primary care, is when I'm interpreting pulmonary function tests. So this is from a family practice document, and I just love to be able to go through this and say, okay, you start with the FEV1 and FVC ratio, and then, okay, is it normal or is it reduced? To walk you through, is it an obstructive or restrictive pattern? I just thought that was helpful to put in there. That's all I have.
Thank you so much, Dr. Breweiler. We so appreciate your time and sharing your expertise with the group. What an interesting topic, and you covered so much about it. So thank you again. We'll open it up for any comments, questions from the group, and I'll give it an echo pause here for some folks to soak in everything they just learned and think of some questions or comments. And I know Dr. Doyle chatted in as well, making a comment about one of your slides not identified in up to 60% of patients. He was saying it's very reminiscent of recurrent urticaria in primary care. I'll let you elaborate, Dr. Doyle, if you'd like.
Sure, I have a lot more, but I want to wait for other people. But just on that particular comment, what Dr. Breweiler said about the frustration and elusiveness of this in primary care, I appreciate your pitching it to primary care. It is really true. And it reminds me, and the fact that you can't identify a specific etiology, and that's if after you've actually got the diagnosis, which we probably miss about 95% of the time. It's a lot like urticaria, recurrent urticaria, since we're trying not to say chronic today. It's about the same. 60% or more of the time, we don't know the cause of chronic urticaria. We have patients with it. We have to take care of them. We do lots of tests, but in the end, we don't know. And fortunately, they get better, and it is not as potentially bad as this is.
Mm-hmm. Mm-hmm. No, I appreciate it, and yeah, the joke about the acute, yeah, acute, subacute, and chronic, yeah. Thanks, Phil.
Thank you, Dr. Doyle. Any other comments or questions from the group? Dr. Wertz, I see you unmuted there. If you had a question or comment.
I have a quick question, which I listened to the list of all the causative things and the symptoms, and it sounds like the same list and the same causative things you would find for occupational asthmas. Pretty much, I mean, and my question is clinically, how do you recommend telling the difference between somebody who has occupational asthma from pick any one of the antigens you listed versus somebody who's moved on to HP? How can you, when should I start to think about that as a diagnosis versus just calling it occupational asthma?
Carl's got good questions. Well, he's not going to get better with the inhalers. Definitely not going to get better with albuterol, like a long-acting or short-acting beta agonist. He might find some, I'm sorry to say he, I apologize. They might, but they're not going to get better. But I would also lean towards sending them to a specialist if they keep coming in, right? Those repeated bouts. That was one of the other ways you could get into this. You could start thinking about this. You know, it's one thing if you're like, okay, it's seasonal. Or I'm sorry, but we're talking about occupational asthma. I'd say, how bad is it? You know, is this slowly progressing? You know, if we have, and you know, if it's mild, okay, but if mild occupational asthma, but if it's more of moderate to severe, I think it's time for him to go and see pulmonology, because we could be progressing to this. I guess it's how often the symptoms are and how well controlled they are, if you can hang your hat on occupational asthma. But that's me as a resident, not as the attending. So I'd love any feedback.
Well, actually, I have a question for you, Dr. Breweiler, about Carl's question, because it was great that you took us through a review of the 4 types of immunologic responses, because we all forget them too. But it seems, wouldn't some of asthma be more in that first category than in 2, 3, and 4? And so I would think that one marker might be kind of quick response on exposure to antigen with asthma. You know, quick response, and like you just pointed out, usually quick get better with bronchodilators. Does that make sense?
Yes, no, absolutely. You know, are you getting better, or are you just, you know, is it lingering? Are these symptoms lingering? Yeah.
Does that help, Carl?
I think he dropped a grenade and ran.
Uh-huh.
No, there we go. No, that does help. It's not, how would I say this? It's not satisfying, but I think it's as good as it gets. So, but yeah, it's a challenge. I just thought there might be some new information in the 2020 document, which I've not looked at. So thank you very much.
The challenge with the 2020 document is it to me, this is my point of view, it leans heavily on this multidisciplinary team, and gosh golly, they want at least that the BAL, right? The I'm gonna say bronchiectasis lavage, bronchoscopy lavage. They want that, and really they want pathology. They want a sample, and they want to talk. In this ideal world, they want to talk to the radiologist, pathologist, and Paul, and they want to get them all together. It's a multidisciplinary team, and that's, I don't know who's going to do that. I keep hearing Cleveland. It appears that folks here go to Cleveland. That's what they tell me, but patients here. But yeah, I think unless you got a good pulmonologist, you can start teasing out. I don't know if we're going to. It's a tough question. I don't have a good answer for it. Have you seen many, Dr. Doyle, of occupational asthmas?
Yeah, I've seen tons of them. I just didn't know it. Oh, well, on occupational asthma, no, not so many, but hypersensitivity pneumonitis, to me, well, first of all, I thought this was really a great presentation, and there was a lot of information in it, and I would love to spend an hour a month just going through this over and over, because there's so much there that's
Okay.
relevant for us. But the
Okay.
primary care perspective, one of the most important things you said to me was keep it on the differential.
Yeah.
Because what happens in primary care, to me, a marker in a longitudinal medical record for this would be that the person is a non-smoker or a smoker and being treated for bronchitis about 6 times a year. And we have many such patients in primary care. So unfortunately, primary care, and now speed up primary care, is if you're coughing, you get an antibiotic, and if you keep coughing, you get a steroid. But we don't think of this. We just label it as bronchitis, just like we tend to label all chronic lung disease as COPD. So we are seeing it. We just don't know it. But if we can learn to keep it on the differential, as you suggested, we might be more likely to think of it after a couple of years of seeing this person over and over.
I was thinking about it. I had a patient recently that's, the more I think about this patient, the more I wonder if it is HP. And his primary care has been giving him, I think, doxycycline. And when you read about it, doxycycline is, when I Googled it real quick, it was more of a anti-inflammatory. I was like, I wonder if that's why he feels better. It's more of the anti-inflammatory effect. Yeah, interesting.
I'm not going to say anything. I'm not going to ask any more of my 20 questions until one of the residents asks at least one question.
We only have one other resident, so
Well, who are all these other people? They're all faculty?
And staff. Staff are here to support the residents too. It's wonderful, clinical staff.
Well, stir the pot with your team, Chris.
I'm going to question him. He's right across the hallway after the session, so.
All right, so he's going to embarrass me off camera. This is good.
I love it. Yeah, no, we welcome any comments too, even if it's not necessarily a question. So, yeah, I love seeing the support from the staff and faculty. It's awesome.
I can give a comment because whenever, and I emphasize this with the residents as well, when we're thinking about both occupational asthma and HP, work in reverse. So as you're trying to work it up, so first diagnose the condition and focus, as Tim outlined very well, on the pulmonary function testing and the imaging. So first make the diagnosis, and only then do you go to step 2, which is try to think about the work relatedness. And he mentioned some of the pitfalls of serological studies, et cetera. I see a lot of people getting the order reversed, and serological studies are almost uninterpretable without the right clinical context, in addition to the problems that he talked about. So always make sure that you're thinking about this as a 2-step diagnosis. First, diagnose asthma or hypersensitivity pneumonitis. Once and only once you've made that diagnosis, then do you think about possible occupational causes and move to that step. And that could be a good exposure history, et cetera. But a good exposure history is going to take quite a lot of time. And you want to make sure that you've got the appropriate diagnosis. So make sure you work in reverse. The studies show that for example, you can have very high prevalence of positive serologies to the thermophilic bacteria among perfectly healthy farmers. And so you don't want to be going down that pathway until you've first made the diagnosis.
I got one other, thanks for that, Chris. And for us in primary care, it's almost a 3-step process. First, we diagnose recurrent bronchitis. Then maybe we think of and get your help to identify HP. and then on to the step that you said, trying to identify a specific etiology. But I want to ask another question while we still have Carl Wernz, and we have actually 3 people, at 4 if you count me, who are part of Black lung clinics in the state on this call. Sheila Morgan is from Mayan in Logan County, and Lisa Emery is from New River, and Carl is at Cabin Creek. And I know Lisa Emery, and Lisa, let's see, are you still here? Yeah, you're still here. Is wanting to know if hypersensitivity pneumonitis is compensable under the state OP program. Lisa, if you're listening, you might pipe up, and I want to see what Chris and Tim say about this. She might be away from her desk. So Lisa would be saying, well, this guy's coughing, he's a farmer, can we file an OP claim on him? Comments?
So I'm going to give the black lung or the coal miner answer, I hope, which is if it's OP from being a farmer, it might be legal pneumoconiosis, that gets always its own weirdness, but it would not be clinical pneumoconiosis. However, if he's got if he got his lung problems from exposure to the isocyanate foams in the mine, it should be compensable. And that doesn't really matter whether it's considered to be pneumoconiosis, whether it's considered to be asthma or whether it's considered to be some other medical condition. But if he was sensitized by the isocyanate foams in the mine, which are used all the time to fill up the spaces when they build the Bradich walls, to fill up the spaces around those, and that should be compensable. Whether the OP board would engage with it or whether they're going to say it's a non-OP occupational lung disease is a different question, but it should be compensable if you can document that it's there and it's related to those isocyanate foams.
But for state OP, it doesn't have to be from the mine. It can be sandblasters who've never been in the mine.
I'm sorry, repeat the very last thing, Dan.
I said for state OP, it doesn't have to be from mining. It can be from any occupation with significant occupational dust exposure.
Right, and the very specific thing I'm saying is that what he has is an allergic condition, which can go on to HP that we're talking about today, then it could be compensable. The question is, in West Virginia, is it really pneumoconiosis or is it a different lung disease? And the way that occupational asthma doesn't go through the OP board, and I would presume HP doesn't go through the OP board because it's not a P, it's not a pneumoconiosis.
So you're saying that the broad definition of coal mine dust disease that now applies under the federal black lung program doesn't really apply for state OP. In other words, under federal black lung, we've heard that, dust-related bronchitis and all of those things might qualify, but in state OP, it specifically has to be a more classical definition of pneumoconiosis.
Well, you have to get in the door, and the problem, and so I think they would acknowledge the pulmonary. They would acknowledge like abnormal pulmonary testing. That would be okay with them. They wouldn't really care what the diagnosis is. But if the person has reasonably well-controlled disease and doesn't test abnormally, but has like bad pathology, that may end up being treated like occupational asthma is, which doesn't go through the OP board. Does that make sense? It's just an administrative difference. But the difference is whether you do your own workup or whether you just send them to Charleston and the people across from the general do whatever magic it is that they do.
Yeah, well, okay, got that. And the practical thing is for physicians like me who were, and others now who are doing it, who are having a stack of OP applications stuck in front of them and said, hey, would you please sign this and check the box, does they have OP? Yes, is what we want to sign off on and what we want to hesitate to sign off on. But thank you, that helps.
Yeah, I would say that if somebody has the history, of mining exposure, I think getting them evaluated at the OP board is a good step regardless. But what I'm saying is they may still have disease that the OP board doesn't acknowledge, and it may need to be you may have to bring that around some other way. But as he said, I don't think this is anything you're going to do yourself. I think this is something that's going to involve a pulmonologist or a pulmonary referral clinic that's willing to do the testing and puzzle out what the diagnosis is, which can be difficult on the best of days. But the OP board, if they have abnormal breathing tests, the OP board will document those. Here's the thing that I don't know, because I'm not on the OP board and I don't see enough of the state claims that are like this to be able to offer an opinion, is if what it looks like is an asthma picture, which I think is what HP will look like until it gets pretty advanced, then the OP board may just say, this is asthma, not OP, and send them on their way and kind of miss the diagnosis, if that makes sense. But again, I think that's what they would do, but I don't know the administrative parts of how they manage. Their processes are, a mystery wrapped in an enigma, foggy day. So I don't exactly know how they manage the not X-ray positive pneumoconiosis.
Love to have more time. Thank you, Tim.
Thank you.
Thank you all so much for the questions and the discussion. It's been wonderful. We are at 9:02 a.m., so I want to just keep in mind the time for everyone. I know it's a Monday, so it must be busy for you all, but big shout out to you all. Any other comments or questions you have, you're more than welcome to email me, and I'll pass them along to Dr. Breweiler, and he can, address them, and I'll send it back and, be that little buffer in between. So thank you so much again, Dr. Breweiler, for joining us today. You did an incredible job presenting, and we appreciate you doing the answers for any questions and stuff that came in too. And again, big shout out to the residency groups and the program directors who are joining us today, Drs. Martin and Welchik. Thank you all so much. So I hope you all have a wonderful rest of your day, and we'll see you next time. Take care, everyone.
Thanks.